introduction and for inviting me here tonight. It's always just such a pleasure to get together with this group. So for tonight, I was asked to give a bit of an update on what's new in the area of HIV treatment. And you know, it's actually a pretty exciting time right now because there have been some new developments, both in the types of drugs that are available as well as the way that these drugs are used. So that's what I'll try and spend the next little bit giving you an overview on. So yeah, just I'll talk about some new drugs, some new treatment strategies, and some things to keep in mind if you know, the topic of switching treatments comes up. So there are some, after a bit of a, I wouldn't say drought, because there are lots of great drugs to treat HIV, but after a couple of years of staying the same, there have been some new drugs that are here now in the recent year. So the first drug I'll talk about, I'll mention, is called bictegravir. So bictegravir is an integrase inhibitor. There are already 3 other integrase inhibitors out there that people you may know of, you may be taking them, or you maybe know people who are taking them. So they're quite commonly used now. So what do we know about this new drug? It can be taken once a day. It doesn't have to be taken with food. It's very potent. It can, it's part of a combination tablet. So people who are on this drug, it's a pill that contains 2 other medications, so it can be taken as a 1 pill once a day. Right now, it's not covered by the Ontario Drug Benefit Formulary yet, but some private plans are covering it already. And yeah, just to, this is a busy slide, sorry, but just to show you the other similar drugs in this class, you can see there are some differences. One of these drugs called elvitegravir, it has to be given with a booster called cobicistat. And because of that booster, there is a risk of drug interaction. So that's kind of one drawback with this that the newer drug bictegravir doesn't have. We know raltegravir or Icentris was the very first integrase inhibitor that was marketed. You know, an excellent drug, because one of the main disadvantages is that it is generally given twice a day. So right now everyone seems to want, you know, once a day. So that's one of the drawbacks of that drug. It's also not combined with anything else in a single pill. So if you're on Icentris, you really usually are on other medications, like separate pills to go with it instead of 1 pill a day. One nice thing is it is still a good drug to use in pregnancy, whereas some of these other ones are not recommended right now. So there's lots of little, you know, interesting differences, minor differences. Yeah, you can see that when in one study, when bictegravir was compared with dolutegravir or Tivicay or Triumeq, you may know it as, you can see they're both almost identical in terms of effectiveness. Both in terms of bringing down the HIV viral load, you can see the exact same curves. So that's quite nice. Where is bictegravir going to fit in terms of therapy? So as I mentioned, it's part of a 1 pill once a day. So bictegravir is combined with the emtricitabine, which is a nucleoside inhibitor, as well as tenofovir alafenamide. So these 2 drugs, you might also refer them as Descovy, and it comes separately, but this is an all-in-one pill. So it can be used as a first choice for someone who's never been on treatment before. The side effects are pretty minor. Like anything, there might be some initial stomach upset or nausea, a bit of diarrhea at first, but most people seem to have very few side effects. As I mentioned, it should be avoided in anyone who's pregnant or may become pregnant right now, just because it hasn't been studied and we want to be safe. There are some drugs that can interact with abacavir, so as always, check with your pharmacist if you're not sure. And like all the other integrase inhibitors in this class, you have to space them, take them at a different time if you're also on anything that contains calcium or magnesium or iron. Supplements or antacids, they should be taken at different times. So who might want to use this? Like I said, if someone's starting therapy for the very first time and they want a 1 pill a day option, that's a good choice. And if they want this particular combination, the tenofovir, alafenamide, or TAF, and FTC, Triumeq is another 1 pill a day, but the backbone in that is 2 different drugs, abacavir and lamivudine. So if some people have a problem taking abacavir, for instance, they can't take Triumeq, they could take this Biktarvy instead. And the advantage of the tenofovir, alafenamide, or TAF, it's might be a little safer in terms of effects on the kidney and bone. Now, it doesn't have need a booster, so it has fewer drug interactions. And again, if you want to take it at this point, you're going to have to have private drug insurance. It may also be something to think of for people who are on therapy right now but want to switch to something else for one of these reasons. Again, just talk to your doctor first to see if this might be an appropriate option. There's also a non-nucleoside reverse transcriptase inhibitor called doravirine. So the non-nuc and an RTI class. Other drugs include Atripla, nevirapine, for instance, Viramune, Atravirine, or Intelins. So what does doravirine look like? It's again it's a 1 pill once a day. You can take it with or without food. Very, very potent, very active, and it's also available alone by itself or as part of a single tablet regimen. So lots of flexibility there. If we compare it to some of these other drugs, so rilpivirine or Complera or Odefsey, for instance, you know that with the Odefsey or Complera, it has to be taken with a meal because you need food for proper absorption. It also shouldn't be used if someone's got a very high viral load or very low CD4 count. It also has interactions with like antacids or acid-reducing medications. We know that efavirenz is an effective drug, but it can lower drug concentrations of other medications that you might be taking, atravirine, kind of similar thing. So you can see there's a lot of advantages to doravirine. It sort of has gotten rid of a lot of these problems that the other drugs in this class have. And when they've done studies, they've compared it compared to efavirenz or Atripla. It's been just as effective in terms of suppressing viral load. And when they've compared it with boosted darunavir ritonavir, so protease inhibitor, also just as good. So that's a really nice information to see. Where is it going to be in terms of place in therapy? Can you use it as a first-line regimen? Sure, I think that's where they really want to place it. The only drawback at this point is it hasn't been compared head-to-head with an integrase inhibitor type regimen. And those are the most common ones that people starting treatments now are using. So that's something that I think some people might still want to see. Yes.
I thought it was not recommended for treatment experience. Why?
Doravirine?
Yeah.
Right now it can be either, but the single tablet regimen is really only for treatment naive. But there might be times where you could use it in a more treatment experienced patient and use it to replace something like a traverine or rotulitine. Side effects, kind of the same as in this class. Headache, nausea, diarrhea, maybe some dizziness or some insomnia or dreams. It's, again, something that this class seems to all have in common. For now, avoid it in women who are pregnant or breastfeeding, again, just because it hasn't been studied. And also there are some drugs that can interact with doravirine. Who do I think should use it then? Again, people who are starting treatment, you want one pill once a day, because it comes both as a combination pill as well as on its own, it really can be mixed and matched with any nucleoside backbone. It's got fewer drug interactions than other medications in this class, so that's a real advantage. So I can tell you so many times, when we wanted to use something like Complera or Odefsey in a patient, oh, I'm on pantoprazole, I'm on a proton pump inhibitor because I have heartburn, and then right away you can't use that drug. But doravirine you can, it doesn't have that interaction, so I think that's a big plus. And again, you have to have private drug coverage at this point. And it might also be a good option for people who just, are already on a non-nucleoside but want to switch to something that is a little easier. And now, those are the two new drugs, mostly for treatment-naive patients. There are also some new drugs for more resistant HIV virus. First one is called Fostemsavir. It's not licensed yet, but we're told it's pretty close. And so it's a prodrug, and it's an attachment inhibitor. So it prevents the virus from binding to the CD4 cell. So it doesn't even, it blocks the binding so it doesn't attach and even enter the cell. Nice thing is, because it's a completely new class, there's no cross-resistance with other medications, other classes. It's given twice a day dosing, 600 milligrams twice a day by mouth as a pill.
Question, does that work similar to Fusion then?
Fusion works at a slightly different step in the attachment in that entry. So same kind of general idea, but not the same. So this is one study. It's called the BRIGHT study, where Fostemsavir was used in people who had lots of treatment resistance. And you can see there is quite a big difference in the people who got the Fostemsavir plus whatever other drugs they were taking versus placebo. And these are pretty high numbers for, I'd say, people who've not had much luck with a lot of other medications. So I think that's really, really promising. The other new drug is called Ibalizumab or Trogarzo, and this has been approved in the U.S. already, not approved in Canada yet. So this is a monoclonal antibody, which also acts as an entry inhibitor, but different from fostemsavir and different from Fusion. So all kind of complementary. This one is given by injection. So you get a loading dose first, one injection, and then it's an injection every 2 weeks. So remember Fusion was twice a day, injections twice a day. This is once every 2 weeks, once you get started. Yeah. So, you know, pretty minor side effects, and again for people with very resistant to virus. You can see in pretty small numbers, but it has been shown to have some good efficacy, again, in people who don't have a lot of other treatment options. And so ideally you want to try and use this with, you know, one or more other drugs that, you know, the virus is still sensitive to. So for the longest time, really for the last 20 plus years, we've always said 3 is the magic number. You're on 3 drugs at least, and it's kind of an all or nothing. So if you're having problems with one drug, then you can't just stop that and keep taking the other 2. You have to stop everything, go see your doctor, stop everything, and start something else new. So traditionally, it's been 2 nucleoside agents, so your backbone plus either an integrase inhibitor, a non-nucleoside, or a boosted PI to make the 3. So this is quite a new concept that is now, people are now starting to use. It's called going back to using 2 drugs. Okay, so you don't get to just drop the one drug you don't like. It's not, it's a very particular.
I was getting excited.
I know. So right now there are only very specific 2 drug combinations that are kind of approved or being looked at. They are dolutegravir and rilpivirine, dolutegravir and lamivudine, or darunavir, boosted darunavir plus lamivudine. How can you use these 2 drugs? In some cases, people might actually be able to start with 2 drugs, sort of as a brand new regimen. A more common, I guess, option is to use it as a switch. So if someone's already taking medications and the virus is suppressed, and they want to just switch to a 2-drug combination, that's another way. And I don't think I need to go over, belabor why 2 might be better than 3. It's less pills, less drugs, possibly fewer side effects. You can sometimes avoid drug interactions, less cost, because you only pay for 2 drugs rather than 3, depending.
So is it recommended only for newly diagnosed people, or also a switch?
Right now, Kristen, if you just want to go back to the slide before. Right now, the route that most people would feel safest with or most comfortable with at this point, because it's still pretty new, is as a switch strategy. So I would say most of the time in someone who's starting off a treatment brand new for the first time, it's still going to be a 3-drug regimen. More commonly for right now, it's going to be the 2-drug is going to be after you were suppressed, and then possibly switching. This one combination is a combination of dolutegravir, which is an integrase inhibitor, and rilpivirine, which is a non-nucleoside agent. So these are available in a single tablet called Jaluca. And so this is the first product, 2-drug product, that has been approved as a switch therapy. They say it can be used if you've had your viral load suppressed for at least 6 months, but I would say most people would probably want to see longer, viral load less than 40 or undetectable for at least a year or 2. Longer the better. also, it's an option if you don't need the nucleoside backbone. And remember, a lot of the nucleoside drugs also work to treat hepatitis B. So if somebody has hepatitis B, this is not a good choice, because you would still have to add on these other drugs anyways. And this is, of course, only going to be effective if your virus is sensitive to both those drugs. If you have resistance to rilpivirine or resistance to dolutegravir, this is not a good choice. So I said, again, not good if you have active hepatitis B. Still some drug interactions. So any drug interaction that we would normally have to look out for with dolutegravir, Tivicay, or rilpivirine, like Odefsey or Complera, it's the same thing. They're the same drugs. There's nothing new about them except they've just been paired up together on their own. And again, pregnant women or women who may become pregnant. There have been some studies, the SWORD studies looked at using this two-drug combination as switching, and they compared it here, the switch versus people just staying on their combination therapy. And then after a year, everyone was able to go on the two-pill regimen. You can see the rates of viral suppression were as good in the people who switched to the two-drug compared to people who stayed on their current two-drug regimen. Another two-pill option is the combination of dolutegravir, so the integrase inhibitor plus 3-TC, or lamivudine. If you look at the U.S. treatment guidelines, they were just updated 1 month ago at the end of October. And this was added as a potential, not just a first-line regimen, but in some cases, they said this could be a possible option to start people on. And it's in those rare instances where somebody cannot take abacavir or tenofovir. Also, it should not be used if the baseline viral load is very high. Again, there's a caution about becoming pregnant because of dolutegravir. Like I said, hepatitis, the 3-TC is, or lamivudine is good for hepatitis, but it usually has to be given with tenofovir. 3-TC on its own is only has some sort of temporary effects for hepatitis. Again, there are some studies comparing the two-drug dolutegravir 3-TC compared to dolutegravir plus tenofovir and FTC, the standard triple combination. You can see almost identical results in terms of viral suppression. But again, all the things that we listed in the previous slide of having a low viral load or not being resistant, those are the people that they studied in this trial. Finally, the last two-drug combination is darunavir with ritonavir, again, plus 3-TC. So the same reasons as the dolutegravir 3-TC, it could be used as a first-line option if these other drugs cannot be used. If you've got someone who can't take abacavir or tenofovir. But for all those reasons, the same precautions for hepatitis, drug interactions, or pregnancy. Again, notice these slides all look the same. There's a comparison, and then everything looks the same, which is good news, right? It's great that all these regimens, whether it's 2 or 3, they're all excellent results. What else is coming down the pipeline? There's lots, I can tell you, this is like the next big thing. There's so much interest in long-acting injectable drugs. So remember we talked about ibaluzumab, that was the one, and you give by injection every 2 weeks. And coming from a traditional pharmacy, hospital pharmacy setting where our goal is to move away from injection and give everyone medications by pill, because then, then they don't need to be in a hospital, they can just do it on their own. But this is kind of taking the next step, and yes, taking pills every day can give you a lot of independence, and it can be very effective. But now I think people are starting to go to the next level, right? So, for instance, the oral contraceptive pill, normally you take it every day, but now you can go for an injection once every three months, or take a patch. That's the kind of strategy that they're now trying to look at with HIV drugs. This study shows use of two injectable drugs. One is called cabotegravir, which is an integrase inhibitor, and it's given. And this study was given with rilpivirine. So we know rilpivirine as an oral pill, but they found a way to make it into like a nano suspension and give it by injection, so it lasts for weeks and weeks and weeks as well. You can see in this study, everyone started off on the oral medications, because the problem is once you inject something that's long acting, it's in your body for a long time, which is great when you want it to work, but if you're having some kind of side effect, you're going to be dealing with it for a long time until it finally clears your system. So to be safe, anyone who wants to go on some kind of injection type of protocol, there's always like a lead-in period where you get the same drugs by mouth, orally every day. So you can see, just on the off chance that there is some kind of problem, you can stop the drug and you're done. Right? You're not stuck with it for weeks or months in your system. What are some things you should think of if you're interested in switching therapy? I think one of the most important things is your viral load suppressed. And if it is, the longer the better. I would just say, some of these treatments, they say, oh, you should be virally suppressed for at least 6 months. Like I say, the longer the better. 1 year, 2 year, 5 years. It just shows that your body is really, you have gotten into a really good habit of taking medications. Your body's responding really well, and that virus has really just been kicked right down. If you're interested in reducing the number of pills, that can be appealing, or are there certain side effects that maybe you can get rid of? Obviously, the drugs that you're going to switch to have to be completely active. You have to think, and whatever you're going to switch to, new drug, maybe there's going to be new side effects or new interactions. What's the cost? We always think newer is better. In terms of the cost-wise, just to be aware that now some of the older HIV drugs are sold, there are now generic products out there, generic versions. So they're actually a lot cheaper than sort of the latest. And that, that can be an important thing. If they work, all these slides, if they work exactly the same, maybe you don't always need to get the brand new Porsche, right? So the guidelines do say, so remember at the beginning I said, when you can go down, sometimes you can go down to 2, it's just, you can't just drop any one that you like. So the 3 pairs that I talked about are the 3 approved 2 drug combinations. And I'll just tell you, in the past, the 2 drug combination has been studied. And there's been a lot of times where, or even 1 drug, and it didn't work out. These other, going down to a PI or an integrase monotherapy, certain 2 drug combinations with older drugs actually were not as effective as staying on 3 drugs. So again, it's really, you've got to go by the books and make sure you're doing it with your doctor who knows exactly what the right choice is for you. Okay, so just to summarize, I think it's nice to know that there are some new agents now that are already here for treating naive patients for HIV, and they're all generally very well tolerated and safe and easy to take. And I think it's also great news that there are some new drugs coming for resistant HIV, because some people still have these these challenges and are on some pretty complicated regimens. So I think that's great that they haven't given up and they're still pushing these through the pipelines. As for two drug approaches, I mean, I think that's quite a revolution. And so certainly for some people that can be something to look into. I would say right now probably the most the one that's the most marketed is the dolutegravir rilpivirine or Juluca, because that's already out. It's approved. It is being used. These other two, dolutegravir 3TC or dolutegravir 3TC, they're newer ideas. So there's not as much experience. We might see, and for now, they're only all the pills are taken separately, so they're not going to. It's not going to be a one pill a day option. I will say though that I think the dolutegravir 3TC combination, they're both made by the same drug company. And I think they've already filed an approval to have a one pill with the dolutegravir 3TC. So I think when that becomes available, that might sort of move up to the top of the list. But for now, it's just something to maybe try under specific conditions. Like I said, monthly injection combinations are being studied. Yes.
Would the injectable be cheaper than taking the daily pills?
That's a good question.
Yeah.
I have no idea. I think because you're going to have to weigh it against. Do you have to go to the doctor to have it injected, or is that something you can do at home or at a pharmacy? I'm sure the people making this want to get every penny back from their investment, so I don't think it's going to be cheap, as cheap as maybe some of these other products which have been out for longer. So I'm very interested. I have no idea what the cost will be.
Is the needle intravenous or to the muscle?
For some of the drugs, it's intravenous. For these long-acting ones, it's intramuscular. I am. In your butt.
I'm just worried about any information with hepatitis C and the new medication. Because in the past we're recommended to stop HIV treatment, especially with the new hepatitis C treatment, do the treatment for the 6 weeks, then go back on the HIV treatment. Looking at the new drugs and the two drug combinations, is it still the same? Or can you do your HIV treatment and your hepatitis C treatment at the same time?
Yeah, that's a really good question. I think there's so many great hepatitis C treatments out there. Some of them do interact with certain HIV medications, but I think these days it's more easy to, what we were trying to do is switch. If you're on a combination that interacts with hepatitis C drugs, we would try and switch your HIV treatment to something else which doesn't interact. Because hepatitis C treatment is usually,
6 weeks.
say 8 to 12 weeks. It's short. It's a couple of months. So during that time period, you might be able to go on something else for the HIV. And if you like it, stay on it, or if not, kind of switch back to your old regimen after you're done with hepatitis C treatment.
How far are we from finding cure?
Yeah, I think it's still kind of in the distance. Yeah.
What's the reason why it's still in the distance? Like, what is it just that complex that it's?
It's such a clever virus that it really is difficult to find one thing that will be protected.
Yeah.
Right now, what's the difference between Calitra and Truvada compared to other drugs? This is an older drug, right?
Yeah, so it's an oldie but goodie. So Calitra is, sort of the first boosted protease inhibitor to come out. These days, there are other similar drugs which are easier to take. If people want to switch to something like Prescovix, for instance, then it's just one pill a day. rather than 2 pills twice a day. Or,
I do have a question, Alice. Like, when Genvoya wasn't approved yet, right? For
Yes.
ODP, and now it's being approved, but they still actually, they still want to keep the patients. Like the pharmaceutical companies still want to keep the patients. They say, okay, you don't have to pay for the drugs, you don't have to pay for the drilling portion.
yeah.
Is there a reason why? Just because they want to keep the patients in loop with their drugs?
Well, I'm sure, yeah, I mean, the companies, they want to keep as many people, well, really on any of their products.
Right.
So, the people who make Genvoya are also the ones who just come out with Biktarvy. So, it's really, I'm sure they're going to start seeing people, moving from Genvoya. If they're going to move to Biktarvy, I'm sure they'll be totally fine with that because it's still still their same portfolio.
So Biktarvy, is it very similar to Juluca, or it's totally different class?
Different. Think of Biktarvy being very similar to Triumeq, except instead of the abacavir 3TC backbone, it's tenofovir alafenamide and FTC backbone.
So if a patient a long-term survivor, right?
Yeah.
Is there any specific or recommendation whether they should go with certain drugs if they want to switch to?
I think that's going to be a very person-by-person answer, depending on what they've been on in the past and if they've had any sensitivities or reactions or resistance to anything. I think as these new drugs come out, definitely there's interest in trying to update people's regimens. If there's a way that you can go from taking, this number of pills down to this many, and they're just as effective and just as safe, then why not? Same time, I mean, I know lots of people who are on their combination, they've been on it for 10 or 15 years and no problems, no side effects. They have, why change? And if it's not causing any problems, then sure, why?
Yeah, I mentioned before the Coletra and Truvada.
Yes.
What kind of side effect they have compared to the new one?
Okay.
And are there more side effects than the new one?
So I'll start with Kaletra. So Kaletra is a protease inhibitor. So it tends to, can cause diarrhea, stomach upset, high cholesterol, for instance, or maybe high blood sugars. And again, I think as people live longer, get older, these might become more concerning over time. So. So some of the newer drugs have less of these side effects, so that might be a good reason to switch. The Truvada is, it's still a first-line option. It contains the tenofovir disoproxil or tenofovir TDF. And that can sometimes cause problems with kidneys or with bone density as people, if you're on it for a long time as you get older. There's a newer version of tenofovir called tenofovir alafenamide or TAF. And that's safer than it doesn't really have the same side effects on the kidneys or the bones. So it's available also combined with FTC as Descovy. So instead of Truvada, Descovy is the newer version of Truvada, and that's thought to be a little more improved.
So do you think it's better to switch a newer drug or keep doing the old one?
I think, Descovy isn't covered on ODB yet. So right now the only way you can get it is if you switch to a whole new regimen like Genvoya or Complera or Biktarvy. But that's the only way to get it. I'd say for somebody who already has, if you're worried about your kidneys or you're on other medications that can affect your kidneys, if you have osteoporosis, some of these other things, then it might be might be something might be an idea to switch.
So if that's the case, would it make more sense that depending on the age group of the patient, the doctor should look into like getting bone density tests or other tests before they switch it?
Well, in general, checking bone density should be something that's done on a regular basis once people, just anyone in the population.
Yeah,
general
as
population.
advances.
Yeah.
When you mentioned Prescobi,
Yeah, Prescovics, yes.
Prescobi, is it the one that combined with insulins in it? Or is
No.
it that's the
Prescovics is darunavir and cobicistat in one pill together. So it's your boosted protease inhibitor.
And that particular drug is still using widely or no?
For people who need a protease inhibitor, I would say it's very popular. So we use it a lot, especially in people who had treatments in the past and have some resistant to virus, and the Prescovics is very, very potent.
My question is a little bit funny because if the patient takes Truvada together with isoniazid, and she only supposed to take 2 isoniazids a day, but she takes only 1, and 1 Truvada plus 1 isoniazid, that means only 2 tablets a day, and the patient still have undetected viral load and CD4 still over 400, between 400 to 600 for 10 years, never detected viral, always undetected, and CD4 always between 400 to 600. Can she just take Truvada only?
I
Based on
wouldn't.
history.
I wouldn't recommend it. I mean, first of all, I think for this scenario, it's working well, but I would never recommend taking half a dose of any of these medications.
But it works. But my
But
question
it might
is,
not work for everybody, and the problem is if you only take, half a dose, then, and it doesn't work, then the virus will become resistant to that medication and maybe that whole drug class. So I think it's
the reason I raise half of the dose because they don't do the research on people who have 200 pounds, take 2 tablets a day. Then me, 85 pounds, still take 2 tablets a day, that means too much. You see? Until they do the research based on weight.
Yeah, they are starting to do some weight adjustments. So efavirenz, normally the dose is 600 milligrams a day, but now it can be, they say for certain weight groups it can be lower. But again, I think with HIV, because if the risk of going too low is that then it won't work, the virus will become resistant, not just to that drug possibly, but to many others. So I think traditionally they've gone with the one dose, one size fits all, just to be safe, any kind of adjustments that people want to make, I think that's really one-to-one with your doctor discussion.
Just perhaps maybe 1 or 2 more questions. Just minding time, so it's almost 8:45. Yes, so maybe Jerry can also suggest I see your podium hand up.
So on the slide, the second point, does it mean like if someone is undetectable, then they can consider to switch just like the route to earlier?
And the filtering?
And? Does
Yes.
that mean and?
Yes.
So those 2 together?
Yeah,
Oh.
as long as the virus is sensitive to both those 2 drugs.
For my last question, you may not have an answer to it, but I just want to bring to light in the past, risk reduction with ritonavir as a booster. It interacted with certain substances, illegal substances, street substances, like crystal meth. Is that risk reduction lessened now that we do not use ritonavir as a booster, like a total combination?
Yes, it is, but just remember that products like Genvoya or Stribild or Prescovis, anything that contains cobicistat is just like ritonavir, it's a booster.
It's a booster,
So you can't just because you're not on a PI, you might still be on a combination that has a booster in it.
So everyone, we really want to give a big round of applause. There's a lot of interest in the presentation, so we'll be sending you the slides for sure. And hopefully we'll see Dr. Tsang, I'm sure, next year again with more updates. Thank you for coming to the health promotion workshop. Remember to fill out your workshop evaluation that Momo's passing out. If you have not completed the year-end evaluation, the green one, please do so as well. And also, can we also give a big round of applause to Min of the Pumpkins team.